sorry for some little mistake. My name is Shi Wei. I'm a surgeon, HPB surgeon from the University of Hong Kong Shenzhen Hospital. And thanks for the host, Dr. Matos and Dr. Pascal, and give me this chance to share a case in our trauma center. Today, my topic is the traffic accident with burn injury. So at first, we can see a video which show the injury condition at that time. It happened on the last year, November 24. We can see traffic accident occurred, and it has the burn at the same time. So the patient is a 32 years old male patient. He ride the motor at the same time and got a traffic accident with burn injury. And the pre-hospital care brought directly to our hospital. The time is approximately 40 minutes. And our hospital has activated the trauma team before the patient arrived in our hospital emergency department. So the primary survey, according to the ATLS principles ABCDE, the A is inhalation. We can find inhalation injury. And the breath, we can see the respiratory rate is 35, is quickly. And he also has the diminished respiration in the left chest. And the circulation showed the blood pressure is 104 to 54, and the heart rate is 116. And the FAST showed the splenorenal and the pelvic cavity are positive. Disability show that the GCS is 9. Which include E2, V3, M4, and the pupil bilateral are 3 centimeter, 3 millimeter, and sensitive to the reflect. And the exploration showed that the TBS is 50%, which include 10% deep degree 2 and 40% degree 3. And the patient also, we also found the patient has the left lower limb shortening with the deformity. So after that, we do the intubation and also give the patient the cervical gel, and also start the IV fluid resuscitation at the same time. We also give the patient O-type red blood cell transfusion at the same time to release to cure the shock. And we also do the wound dressing at the same time for the burn for the burn skin, and tetanus human immunoglobulin at the same time, and also keep warm for the patient. This is a CT scan, the portal phase to after the rescue, and we send to patient to do the CT scan. From the CT scan, we can see the spleen injury, and also we can see the left kidney injury. Okay. So here's the discussion. So what shall we do next?
Dr. Hout?
Dr. Hout.
Sure. So I think my first other question is, I'm glad to see the CAT scan, but I was also expecting to hear something about his head CAT scan, and I'd just like to know, just to be clear, does he have anything in his brain that explains his decreased mental status and decreased GCS?
Yeah, the patient the GCS is 9, and the CT of the brain shows no cerebral bleeding inside.
Okay,
Yeah.
thank you.
And no cerebral hernia. Yes.
Okay, so I'm less worried about his brain. Clearly, I'm worried about his abdomen, and that's the number one priority now. So in my mind, there's 3 options: watch and wait, laparotomy, or angiography. So I guess the question is, I would have to look a little more closely at the CAT scan and see. I don't know that I saw a lot of free fluid, but I certainly see the injury to the kidney and the spleen.
Yes.
If the patient is, I don't love the word hemodynamically stable, but the lowest blood pressure I heard was 105, I would probably take this patient to angiography. We do not have a hybrid suite in our hospital, but I think many people would say, oh, this is a perfect case for a hybrid operating room. Angiography for the spleen and the kidney, and then if you need to, you can go ahead and address and do a laparotomy if need be.
Yes.
Dr.
Thank you, Professor.
Dr. Alessandrino, I know that in Europe sometimes you have some different protocols. Would you take this patient CAT scan, or send this patient straight to the operating room? Or how would be your protocol? Anything different that should be done? And your comments about the burns as well that patient has from the pre-hospital.
Yeah, it's an excellent case. Congratulations. My question is, we tend to simplify the presentation of these cases by only giving one set of vitals, one value for blood pressure, one value for heart rate. I mean, this is not a picture, this is a movie. How is the patient response to resuscitation? How did he respond to 4 units of O negative? Did the patient really need 4 units of O negative? I would say if a patient needs 4 units of O negative, each patient might well be in the OR and not in CT if he really needed them. How was the ABGs? How was the lactate? How was the base excess? Even how is the hemoglobin? That worse for worse is one data, but especially how is the patient physiology? If the trend is that the patient improves and shows excellent response, I would say more than stable. I would say the patient becomes normal with the near normal ABGs. I yes, definitely take the patient to CT scan. It's very important information. Otherwise, if the patient is a low responder, non-responder, or a transient responder, I would take the patient to the OR. And then after that, do the head CT and manage the wounds. That's for me. Since the decision was to go to CT, yes, okay, we can work on that. I would hesitate to take this patient to angiography. This is the portal vein phase. We don't see arterial blush because it's not the arterial phase. But this kidney is, I would say, in pieces, shattered, or then it's most of it is devascularized. And I'm not sure the angiography can adequately deal with this. Not so much for the spleen, but the spleen can be an innocent bystander. And in this, I would say, damage control nephrectomy and also be resected. Again, point by point, whatever your resources are, if you have a hybrid CT, a hybrid OR, and you can manage this patient with endovascular technique while still be able to, if the patient crashes, do laparotomy, that is ideal. Otherwise, for the rest of us, we have angiography 24/7, but it takes some time and it's not the same as the patient being in the OR. I'd be more comfortable taking this patient to the OR. Think of the burns later, think of the head CT after, C before D.
Okay, I have a question. How long was the extrication time? So I know the patient took 40 minutes to be the trauma center, but how long it was inside the car with the car burning? So do you have any idea about that?
Yeah, means the
在现场的话，里面大概有多久？
So it's a very good question. So this is a missed details. The Dr. Zhang Guixi has told me that that's very important. So Professors Metal, you are very special. Yeah, this is a missed information. Yeah, sorry.
Okay. Dr. Hout, do you think the patient maybe had an inhalation injury, maybe has some lung injury? Would you be concerned about sending patient angiography if the angiography is not in the same building or far away, or would prefer having the patient close to you? Would the burns to the airway or possible lung injury interfere with your management?
Well, I think once the patient is intubated, I mean, the most important thing immediately is the intubation. If you delay too long in patients with burn injury and inhalation injury, you miss the window where you can safely intubate them with endotracheal intubation, their airway swells, et cetera. So I think the fact that the patient's intubated makes me a lot less worried. Yes, they might have lung injury that might be worsened by the fluid we give them, by the blood transfusions, but I think for now we'll have to deal with that, put them on a ventilator, and we can deal with that.
Okay, I made this question because I had a patient very similar to this some years ago, and the patient deteriorated acutely. You need to put patient on ECMO and the trauma bay because you are not able to oxygenate him. Dr. Alessandrino, any other comments?
We're waiting, eager to see what's happening. How did you manage this patient?
Can you hear me?
Thanks for everyone's great discussion. Okay.
Can you hear me?
Yep. Let's go on. Okay. Any other questions?
No.
Yeah. I can hear you. Professor
Skubich in Texas. Hey, great presentation so far. I would argue with a guy with 50% total body surface area burns. I would argue against angiography or any kind of watchful waiting. This gentleman's going to require a large fluid resuscitation. Going to be very difficult to tell if he rebleeds after his embolization. For me, I would err on the side of those organs need to come out, or you need to stop the bleeding surgically, because afterwards, when he's in the ICU and you're resuscitating him, how are you going to know if he's just having fluid losses or if he's rebleeding? It can be very difficult to tell. Thank you very much.
Yeah, thanks for your discussion. Okay, so what we do? Why? Because we are in the emergency operation due to the unstable vital signs. Yeah, every professor has told that we need to see the response after the rescue. So that's very important. So we found that during the patient received the CT scan, and the patient's vital signs are not very stable after the rescue. So we decided to do the emergency operation for him. And first, we do the left chest tube insertion because of the pneumothorax in the left chest. And secondly, we do the laparotomy, and which found the huge hematoma in the left peritoneal cavity, and which, according to the CT scan, we can confirm that is caused by the injury of spleen. So we do the splenectomy as soon as possible to stop the bleeding. And we also found that the descending colon near the spleen has injury, and we do the repair at the same time. And we also keep the blood transfusion during the operation. Yeah. So now
what about the kidney?
Yeah. So the patient is still unstable. Now we have done the splenectomy, and we have seen the monitor which show that the blood pressure, and the nurse give the patient the blood transfusion at the same time, but still the blood pressure is still low during the operation. So the vital signs are still unstable. What shall we do next?
So we did not explore the zone 2 at this point, correct?
Excuse me?
You did not explore the kidney at this point, correct? Didn't open the Girotas? No. Okay.
We didn't to do the retroperitoneal exploration. No, we didn't do.
We did not do the retroperitoneal exploration yet. Okay. Dr. Alexandrino, so what should you do now? The patient, they found some injury, but the patient is still unstable.
Yeah, excellent case. Again, this is the time to do a timeout with the anesthesiology team and work with the TBCS mnemonic. It's not just the vitals. You can't just look over the drape and see the vitals. I mean, blood pressure and heart rate can be whatever drugs the anesthesiology is giving. If it's on norepinephrine, blood pressure can be normal, but the cells are suffering. So I would go with TBCS mnemonic. It's something that we use and we train regularly. It was described in Camp Bastion in Afghanistan, the UK teams that use the intraoperative C-traps with the surgical anesthetic team. T for time and temperature, B for blood gas and blood units, blood components. Actually, the patient needs not only transfusion of the red blood cells, but also plasma platelets, fibrinogens, tranexamic acid, etc. C is for clotting. B also for blood gas. C is for clotting. If you have ROTEM or viscoelastic assay, this can be excellent help at this stage. And S is surgical plan. If the patient, I believe, is with the TBC, is unstable, is cold, and in the findings is a left retroperitoneal hematoma, I think that this kidney needs to come out, especially if it's expanding, especially if there is hematuria. This patient needs to be for this hematoma. Should you explore directly the hematoma? I would, in a critically ill patient, I would advise against it. I would dissect the aorta at the level of the hiatus, supraceliac aorta. Make sure there is room to clamp there. It's an easy maneuver. You just push the left lobe of the liver to the right, push the esophagus a bit to the left, expose the supraceliac aorta, prepare for clamping, and then explore the hematoma. You have good inflow control in case there is massive bleeding. So that will be the next step. See, how is the patient, not what are the injuries, how is the patient, and then proceed accordingly.
Dr. Hout, there's some questions on the chat, so I would like your comments. So, do you think that the patient can have like a neck injury, a spinal cord injury, neurogenic shock? Your comments, do you think that the placement of chest tube was a little bit delayed, so you'll be concerned about any tension pneumothorax or something like that, or you think all the hemodynamic problems are due to bleeding, to hemorrhagic shock? And what about exploring the kidney in a patient right now acutely?
Sure. So I think the first thing is, if we knew there was a pneumothorax, we should have put the chest tube in immediately in the trauma bay. You can decide that by EFAST or after the CAT scan before you go to the operating room. I think by now that's not the problem, because that chest tube is placed, assuming it's in good position. That's not the issue. The question about, did the patient move their extremities, and is it possible they have neurogenic shock causing their hypotension? It's always possible. I mean, Occam's razor says there's one problem. One thing should explain it. In this patient, I think it's bleeding, but I think it's a fair question. If I had seen the patient move his legs, arms, and we knew that from pre-hospital, and the CT scan of the C-spine is negative, that basically rules that out. I agree about the part about nephrectomy. Now's the time to do nephrectomy, and there's two ways. There's the supraceliac control, whether it's, get exposure and get ready to clamp it, or just place an aortic occluder temporarily. You can hold it down, directly compress the aorta, because diving into that hematoma and getting the kidney out should be relatively quick. It might take longer to get supraceliac control than it is to really get the kidney out and reach down and find the hilar vessels and take it that way. But I agree at this point, I'm happy we didn't go to angiography. I think more information, you told me, would have made me make the same decision. And I think now there's really no option for that kidney besides take it out.
Dr. Hout, would you place a Ribot in this patient?
So interesting question. I think many people would suggest, and Ribot would have already been in place. I think it very much depends where you work. If you're at a center that uses Ribot all the time and is a Ribot advocate, is probably the nicer word, then they would have already placed a Ribot. It would be above, there'd be a zone 1 Ribot above kidney, above spleen, and you would have that in place as your proximal control. I personally would not. We're not big fans of Ribot at Johns Hopkins. We see a lot more high volume penetrating trauma versus blunt. So we would not have placed a Reboa catheter, but I could understand why some people might want to have done that.
Dr. Alessandrino, your comments about placing Reboa or not?
We don't have it, and I personally have no experience in it. I think Reboa needs evidence. What the evidence shows is possibly in the unstable patient with pelvic trauma, zone 3 Reboa is good to temporarily control bleeding. If Reboa takes so long, and if you're in the initial part of the learning curve, this is not a patient for Reboa. This is a patient for intraoperative control of bleeding, and that's it.
Okay, thank you. Let's continue the case.
Okay, thanks for every professor's advice. So we did the retroperitoneal exploration as soon as possible because according to the CT scan, we can find the huge hematoma in the left kidney. So we called the urologist for help as soon as possible. And before we open the retroperitoneal cavity, we called the anesthetist to prepare and the nurse to prepare. Why? Because we, as the professor Alex Gino have said that we are afraid of the massive bleeding. Yeah. So after that, we do the left nephrectomy immediately. After that, the totally operation time is more than 3 hours, and the blood loss is 3.5 liters, and then the transfusion is 16 red blood cells, 3 fresh frozen plasma, and 1 dose platelet. And after that, the patient transferred to ICU department. So this is the specimen.
Can you go back one slide? Oh. I don't know where the slide went.
Hello?
It looked to me like the ratio of packed red blood cells to the other blood components was not what we would really push for. You know, we're looking for 1-to-1 ratio, and that ratio looks very much not 1-to-1. And I'm just curious if you have a massive transfusion protocol, what comes in your cooler, how that works.
Yeah, we have do the massive transfusion at the same time, and but after the operation, the patient's vital signs are it getting better, but not very stable. Yeah. So this is the specimen. After the operation, we can see a rupture of a totally rupture of the left kidney and the rupture of the spleen. So because the patient also have other injury in the left femur, so we arrange the second operation after the 26 hours after the injury, when the patient was stable, and the fixation of left femur with external fixator and the decompression to prevent osteofascial compartment syndrome. And after that, the patient transferred Shenzhen University Burn Center to cure the burn injury. And when the patient transferred to the center, the patient received multiple dermatoplasty in the center, and also received antibiotics because of the infection, and also received the nutrition support and wound dressing every day. So, any other questions from everyone?
Quick question. I know we're running short on time. Did you leave the patient open for damage control? Because it looked to me like it was a midline closure. And I think in this patient who was unstable, lost 3 units of blood or 3 liters of blood, I probably would have left their abdomen open. But I'm curious what others think.
Yeah, we closed the abdomen at
From beginning
from the beginning
Yeah.
at first
operation.
operation.
Yeah, Dr. Alessandrino, that's a good question. The patient lost 3.5 liters of blood during the operation surgery.
Yeah.
Received a lot of transfusion, not 1-to-1-to-1 ratio, and then you have all the burns on top of that, other resuscitation for the burns. Would you keep the patient open, or keep the patient open and gonna leave to other complications? That's a complex patient management. So how would you do this situation?
Yeah, I have to go with Dr. Elliot Hout on this. The ratio was too much red blood cells and too few plasma platelets. And again, I voiced his concerns on this is a severely ill patient. The burn injury is one of the most severe injuries that a human being can suffer and survive. And alongside with the extreme shock, intra-abdominal injury, this is a very severe patient. We have to remember in trauma surgery, it's not the pathology, it's not the specimen, the anatomical specimen, it's how the patient is. And this patient is critically injured. I would say that this patient was coagulopathic and probably would require some retroperitoneal packing if it didn't require excellent. I mean, good job on the surgical and anesthetic part. That, in my experience, these patients usually require some form of packing, retroperitoneal packing, and obviously open abdomen management because of all the fluid exchange this patient's going to have, ventilatory issues, secondary abdominal compartment syndrome, tertiary abdominal compartment syndrome, burn injury, all that. But again, congratulations, because apparently the outcome was good. But I voiced my concerns, the same as Dr. Elliot Hout, on the ratio and the open abdomen. I would leave the patient open.
Okay,
Thank you.
Dr. Hout, any other comments? So would you prefer to do the case like in 40 minutes, 1 hour, pack, stop the bleeding, pack, and come back next day? Because the case took like 180 minutes. How do you build strategy for this case, Dr. Hout?
I agree. I think, the closure, maybe you're fast at closing, but that still might cut off 20 or 30 minutes, cleaning up and suctioning and irrigating and all that. I would just pack the retroperitoneum and put a temporary abdominal closure on. We use the VAC, but as you know, there's many options. The other part you said was you called urology to help with the kidney. And I'm curious if you waited and how long that took to explore the hematoma. At my center, as a trauma surgeon, we do all the visceral surgery. So, my urologists are happy to come in if I call them for a complex thing that I can't do. But a nephrectomy is actually a straightforward operation, right? The kidney is already floating. All you need to find is the artery, the vein, and the ureter. And it's relatively easy. Now, I've called them for complex, genitourinary gunshot wounds or partial nephrectomy, things like that. But for this case, I would dive in and get the kidney out faster rather than waiting.
Yeah, your answers, your final comments. You have 1 minute to go to the second case, please.
Yeah, thank you. Yeah, very good explain from the Professor Hout. Yes, but in mainland China, I'm a HPP surgeon, so I'm not a urologist. So that's a very, how to say, sensitive because question in our country, because it's not my major now. So sometimes we need to think about more about the, how to say, the safety of the how to say, the surgery. Yeah. Yes, thank you.
This is a very important comment. In some places they have different cultures, difference in the way they approach surgical. I know sometimes, like some places Latin America, we don't do vascular case, we call the vascular thing. So that's why this meeting is so important, to see different ways to do the same thing. They manage the same patient in different parts of the world. Okay, thank you very much.
But
the final slide, and let's go, Dr. Quiodettis, please.
A little minute, Professor Matos, because this is my first time to participate, and I want to show some little pictures, and we can see Professor Hout here. Yeah. So that's very important for trauma surgeon, that we need to do more we can. That means that we can save more lives. So we have the surgical skills trauma center to train our trauma center, the trauma surgeons, and we also arrange the AAST training program In mainland China, we are the only one hospital to arrange that. We can also afford the air ambulance service at the same time. So thanks for every professors, and we are looking forward to your come to our hospital and come to Shenzhen mainland China. Thank you very much. Okay.
That's
Thank you very much.
That's one simple answer to press hold. We after the CT scan, we call the urology directly, and then when we go to the operation, we start operation, and then urologist they arrive. So actually, there's no need time to wait. Thank you.
Thank you
very much. Thank you. Yeah, so let's stop your presentation. Let's introduce the next presenter, next case. He's a good friend. He's Dr. Marta Quiodettis Ponce.
voy a conversarlo con ella. Porque por eso yo te pedía la PCR igual como 4 horas en la tarde.
Please, yeah, Dr. Marta Quiodettis Ponce.
¿Y a qué hora llega?
She's from Panama. She's from Hospital Santo Tomás, Department of General Surgery.
Avísame.
And she's the president elect of Pan American Trauma Society.
Okay.
Please, everybody, mute your microphone. Everybody, mute your microphone, please. Dr. Quiodettis, thanks for presenting today.
Hi, good morning. Thank you, Dr. Antonio Martos. Thank you for the opportunity to let me present this case. Hopefully we can learn a lot about it. So this is a 39-year-old male who came 3 hours after sustaining an injury, a stab wound in the right 6 intercostal space and parasternal line. At the moment that he was suffered from another hospital, so he already had kind of the first evaluation in the other hospital. But by the time he arrived at Santo Tomas, his blood pressure was 94/64, heart rate 150, and you can see he was acidotic with a 6.3 lactate and oxygen of 83. The FAST exam was positive in the abdomen and also in the right chest, and the chest X-ray is the one that I'm going to show you in here. So this is the patient that looks sick. Oh, also, I have to say that by the time that this patient came into the hospital, we were having some social issues and a lot of political manifestations against the mining in Panama. So our blood bank was very, very low running. So we did not have a lot of blood products by this time.
Dr. Alexandrino, how would you proceed from here?
Excellent case. Congratulations. Very challenging. I would say this patient has a massive hemothorax with a right thoracoabdominal stab wound. And obviously, the conundrum here is which cavity first, the right chest or the abdomen? In the right thoracoabdominal injury, I would say the abdomen first, very likely is the liver. But in a trauma surgery, you have to be prepared to be wrong. You have incomplete information. There is no time for CT. This patient is pseudo-stable. He's not stable. His cells are crying. He has lactate. This patient needs to stop the bleeding. I would drape all the patient, make sure the chest is accessible, but I would start with a laparotomy. Regarding the blood, that's an excellent point, and we take it for granted. I would say that this patient has a huge potential for self-saving from the chest tube. We don't know how much drained, but I would ask my blood bank for how can we save this blood from coming out from the chest tube, which even if it's from the liver, let's assume that it's clean blood and with no hollow viscous contamination, and try to preserve as much and to give the patient what he's losing. So regarding your questions, OR and save the blood. Self-saving.
Dr. Hout, Dr. Alexandrino is going to the operating room. Are you intubating this case in the trauma bay emergency room? Are you putting an additional chest tube? If you could go back one slide, please.
So it looks like they already have one chest tube, which looks like it is not draining the chest. I would not do anything else in the trauma bay. I think this patient should get intubated in the operating room. They've already waited 3 hours. Hopefully another 10 minutes won't make a difference. Even in those patients with a short period of time, I still prefer to intubate in the operating room, and there's a little bit of data that suggests doing that. Because when you intubate them and take away their catechol drive, we have all seen this patient go into cardiac arrest, and then it changes your operation, right? So then we're not deciding right chest versus laparotomy. Now you're doing a left side resuscitative thoracotomy, and then the other chest, and then the abdomen. Now they have a really, really, really big operation. So I would take them to the operating room. I would agree. I would be prepared, like we just heard. Sometimes you might be wrong. There's multiple papers over many years about this idea of double jeopardy. You don't know which cavity to be in, and the papers say we're wrong about 50% of the time, abdomen versus chest. So I think be prepared is exactly what I would agree with. Though the only wrong way to do this operation is lateral decubitus and only prepping the right chest. And I've seen that happen, and then they find out it's the liver, and then they have to re-prep and drape. I would agree with Enrique, who said prep the chest and the abdomen all together. I like a bump under the shoulder so you can kind of do a little bit towards the right chest a little better, but you still want that left chest accessible if they arrest. You know, we have not ruled out a cardiac injury. So we think it's lung, diaphragm, liver, but the pericardium is right nearby. You could have easily skated across the pericardium and be in the right ventricle too. So you want everything ready to go. And the only other thing, especially with the blood, the limitations of blood, TXA, tranexamic acid, this is a perfect patient for that. I know it's after 3 hours, and the data suggests you want to give it before 3 hours, but in a limited resource situation where you might not have as much blood as you want, I would still give TXA in this case.
Got it. So both Dr. Enrique and Dr. Hout are heading to the operating room. And one of them is, Dr. Hout is positioning with a slightly elevated right anterior side. Doctor, how did you guys proceed, Dr. Quiodettis?
So we take the patient to the OR and we explored the abdomen first. And we found like there was an 800 cc hemoperitoneum liver injury of 4 centimeters in the segment 8, right diaphragmatic injury of 4 centimeters also. So the surgeon in charge did a hemostasis with liver suture, used some Surgiflow and left a JP. The patient underwent a transfusion of 4 units of blood and 1 unit of plasma and 1 unit of platelet. That's what we have available. The patient received tranexamic acid because we did not have any other thing to help with this patient. And the patient went intubated to the regular floor actually for trauma because there was not available ICU beds. Intubated and with norepi at 0.2 micrograms per kilo per minute. We suture the diaphragmatic injury and we close the abdomen and then take the patient out. Okay, so this was his.
Before we ask the surgeons, was the liver actively bleeding or no longer actively bleeding at this point?
At this point, it was not actively bleeding anymore. So at the time that they made the suture in the segment 8 of the liver and placed the hemostasis, the Surgiflow, the patient was not bleeding at this time. And the chest cavity was also drained with saline water and before the suture of the diaphragm.
Okay, Dr. Hout, are you doing something to the right chest before you close the diaphragm? Are you doing anything to the chest?
So I think it's a great question. I mean, I think in this case, you made the right decision. You went in the right cavity. I think irrigating out the chest via the hole in the diaphragm is a very reasonable option. If you can irrigate it out and then it stops bleeding and you feel as though you've got all the blood out of that chest, and then you have 1 chest tube in there and it's working, I think that's a very reasonable approach. If you keep irrigating and it keeps bleeding and keeps coming back red and you can't get it to clear and you're worried about a lung injury, then I think you need to either do a thoracotomy separately or extend the diaphragm injury, make it a bigger hole to look at the lung. I think if it gets down to that and I'm really worried about bleeding in the chest, I'd prefer to do a separate thoracotomy. Some people would also, push for thoracoscopy, irrigation, things like that. I don't know that this is the perfect patient for that option. So I would irrigate out through the diaphragm, and as long as it runs clear, close the diaphragm, put in a chest tube, and hope that the chest is okay. My only question is, did you guys worry about the trajectory and the heart? You know, when you're in the abdomen, you can do a pericardial window through the central tendon of the diaphragm. And if there's any question, I would have done that as well.
There was no evidence of any cardiac injury at the time of the exposure in the laparotomy, so it was not considered doing the transdiaphragmatic or subxiphoid pericardial window, so it wasn't done.
Dr. Alexandrino, the trajectory looks like it's away from the heart. Presumably the rest of the exploration showed no other injuries in the abdomen other than the isolated liver and diaphragm injury. Any other comments, something you would have done differently?
No, congratulations. The pleural washout is an excellent idea. Make sure there is no bleeding, obviously, like Dr. Hout very well pointed. I would be concerned, this is a stab wound, so stab wounds are nice to treat. They're cool. I mean, there's potential injury would be much different. But fortunately, a stab wound is pretty, I mean, it's what it is. It's what you see. I would be, I noticed that you left Jackson Pratt drain, excellent, because it's penetrating trauma, but if in blunt trauma or gunshot wound, there is a high risk of biliary fistula, and the biliary fistula with a diaphragmatic repair has a very high risk of biliopleural fistula, which is catastrophic. So a Jackson Pratt drain is an excellent idea to make sure that there is no bile leakage. But I would say that with a good liver suture and with a stab wound, there is very low risk for this. But in any case, when in doubt, drain.
Dr. Quiodettis, take us along.
Okay, so perfect. I'm going to just show that after the surgery, he still needed some more resuscitation, and we were trying to keep up on the transfusions. So the patient, after the first post of hours, we continued the transfusion. He was on minimal ventilator support. And we were able to decrease the vasopressors. But on the second postoperative day, the vent settings start to increase, the vasopressors start to increase, hemoglobin level came back from 10.4 to 8.4. We have elevated liver enzymes, we have elevated ammonia, CPK was high, and despite the need to bring the patient to pressure controlled ventilation, and you can see the ABG with 100%, we were not being able to oxygenate. So the patient was getting worse and he looks really, really bad. So we already correct the coagulopathy. This is the tech that we had for that day. And also the chest, you can see that the patient is intubated, correctly intubated with the line in place, the chest tube in place, looking better, but the patient is not doing better. So we start like, what we do now? What is going on with the patient? And we try to get on this diagnostics approach, like is he having a massive thromboembolic event? Is he having also a hemorrhagic shock? Is he on cardiac tamponade? Is he have an abdominal compartment syndrome, ARDS, sepsis? So what we can do now?
Dr. Alexandrino, any questions specifically or diagnostics you want to do now? Do you want to go to the
I totally agree with this diagnostic reasoning at this stage. I would add a vascular arterial injury to the liver, because that very high transamina is a very indicative of liver ischemia. You obviously have to exclude abdominal compartment syndrome, because you have de novo or worsening organ dysfunction. So you need to measure I believe the abdomen was closed. So there is a risk of abdominal compartment syndrome. So you need to measure the abdominal pressure. I would, obviously excluding cardiac tamponade at the bedside ultrasound, I would take the patient to angio-CT of the chest and abdomen to check what's happening inside the chest and inside the abdomen. I suspect the patient made an arterial injury that has a pseudoaneurysm that is bleeding inside the liver, maybe causing intrahepatic hematoma, and maybe at this stage it can be embolized.
Dr. Hout, we're going to ask you, Dr. Quiodettis, did we do an intra-abdominal pressure? Do we know that number before going to CAT scan?
we have a normal intra-abdominal pressure.
Dr. Hout, any other suggestions, or are we going to CAT scan?
So, I mean, the only thing I would do before CAT scan that you would do something different about would be that cardiac tamponade question. And you should be able to do a POCUS point of care ultrasound test very quickly and rule that out. And then after that, I think CAT scan is the way to go. And I think this question, to rule everything out, you want to look at the chest and you want to time this to look for a pulmonary embolism. And then you also want to look at the abdomen in the correct phase to look at arterial injury to the liver. And I think my other question is, at the time of the initial operation, did they do a Pringle maneuver? Were they at all at the hilum? Had they, temporarily clamped the hilum? Is this possible that that caused a dissection of the, hepatic artery? Because I do think I'm a little surprised at the liver function numbers based on only a relatively small injury to, segment 8 of the liver.
Yes, actually, those are very good questions and very good things that we were considering. Like, this is not the regular evolution of a simple stab wound. So something is wrong, something is happening. And we couldn't actually determine what it was exactly. So we do a fast again with the ultrasound, the POCUS. At the bedside, we rule out any cardiac tamponade. We rule out increase in the right side of the heart pressures. That thing that we can see actually easily in the ultrasound. There was no free fluid in the cavity. So we were having very little options of diagnosis. So we sent the patient to the CT, and here is the CT, and you can see, I'm gonna try to do it slower. You can see that the patient has a huge right side hematoma in the liver, and also that there is not so much fluid inside the abdomen. And I'm gonna try to do it slower so you can see.
Dr. Quiodettis, we can't hear you. Are you?
So we were kind of surprised of having the report. Can you hear me now?
Yes.
So we were surprised about, okay, so we were surprised because the report of the CT showed no bleeding inside the liver. Okay, so you can see that there is a huge hematoma in the right side of the liver, no free fluid, and we were not very sure what was going on this patient. Let me show you the next one.
All right. Oh, we got some coronals.
There is no showing of any active bleeding except for the huge hematoma in the right side, intraparenchymal hematoma.
Any other CAT scan results that we need to know about, Dr. Quiodettis?
No, but we went ahead and talked to, there was nothing in the, like no TEP, nothing in the heart or the lungs. So what we do, we went to talk to radiologists.
Hold on a second.
So, yeah.
Doctor, how would you, the patient is on multiple pressors at this moment, is that correct? With a hemoglobin that's dropping, Dr. Quiodettis?
Yes. He's on norepi at 0.2 micrograms per kilo.
Dr. Hout.
And do we, I guess my question is, do we think that's bleeding? So the teaching should be, if a patient is bleeding and that's why they're in shock, they either need an angiography or they need a laparotomy. I'm still not clear why they're in shock, right? There's not that much blood. If you told me their hemoglobin dropped 4 points and there's a belly full of blood, I'd believe that more, that he's bleeding. There's no real blood in the chest. I'm still not convinced of what the diagnosis is. I'm not convinced you have to go to the operating room. I would be okay with interventional radiology to angioembolize and see if there's anything deep in the liver that is much easier to get by angio than it is by surgery.
Dr. Alexandrino, we're going to IR for an angiography plus or minus embolization. Are you in agreement?
Yes, totally. I mean, this patient, obviously, this hematoma is not there. These are subcapsular hematoma. Looks like the what you see in a subdural hematoma. It's concave and convex that compresses the liver parenchyma. It's very similar to the image of a subdural hematoma. It compresses the liver parenchyma. And I would say that this patient, probably there is a minor bleeding and pseudoaneurysm there that's feeding this hematoma.
So we talked to IR because we were actually having the same processes that you're having. And we were like, something is wrong and we do not know exactly what it is. So the patient was taken to the angio suite. And you can see in here a communication between, this is the arteriogram, and you can see a communication between the arterial and the portal phase just right away. So they found a significant hepatic arterioportal fistula of the right anterior hepatic artery. And it was really, really hard to embolize and do the micro catheter things that they place inside the arteries because of the hematoma. So these patients went and have this closure by the radiologist. It took them like 4 hours to complete the procedure. But after that, the patient started recovering and improving. So you can have in here the post-embolization arteriography that it has. You cannot see like very well the microcatheter over there. So the evolution of this patient after this, so we start decreasing the vasopressor, decreasing the ventilatory support. We were able to initiate enteral diet. The liver function started normalizing a little bit, and we have this JP output of 200 cc serosanguinous and the pleural tube of 60 cc also serosanguinous. So after day 6, still in the ICU, the patient started dropping again 2 grams of hemoglobin level. And we did another control, and we can see over here that the hematoma is still increasing a little bit. And also that there was also opacification of the portal system with the arterial phase. So at this time we did another, we got again for another angioembolization, and this time the doctor occluded the right anterior superior hepatic artery and completely embolized the right hepatic artery. So after that, the patient started again getting better, but we were concerned about all the yes.
What did they find? Was there extravasation, a pseudoaneurysm? What is it that, what's the reason they re-embolized the right hepatic artery branch?
There was still a communication between the artery and the portal phase of the, so the fistula recanalized or did communicate again. So they had to embolize the right hepatic artery. So after that, just to remember everybody, like that's the irrigation for the or the rim of the cystic artery. So we were concerned now of all these issues related to the gallbladder and also having a fistula formation after that. So the patient was still improving a little bit. So we had to deal with these healthcare associated infections with the ventilator. And we did a follow-up study after that for CT. And we can see that the patient already, the way that the hematoma was improving, becoming more liquid, more decreasing the size of this hematoma after the second embolization. And just to follow up, the patient went home after 30 days in the ICU, and we were able to send him home with this hematoma, in a very good condition. So that's the case that we have to present, and also for everybody to have this bibliography available. This is from Jason Sierreta group with a hepatic arterial portal fistula following liver trauma. They have a 5 case series and a review of the literature. And after doing this for a couple of years, not so many, but a couple of years, this is the first time I can see a patient presenting with this type of shock after having this arterial portal fistula. And thank you so much for listening.
Thank you, Dr. Quiodettis. Dr. Hout and Dr. Alexandrino, do you want to give some closing learning points from this or the previous case, please?
I'll just say this is a very interesting case. We see a lot of pseudoaneurysms and a lot of arterial bleeding in the liver, but the arterial portal fistula is not a common one. If we had known what that was, I wonder if a covered stent might have been a better option. If they can see where the injury is in the artery, to cover that instead of trying to embolize it. I'm curious to read this paper and see what they did there. But I think you were right to think, I've been doing this a long time and I've never seen this before. It was not a normal case. And you had all the experts here saying there's something that's not quite right. And I appreciate you thinking through that whole big differential diagnosis list to start from the beginning and came to the same conclusion we did. But I think you have to start from the beginning. What did we miss? Did we miss cardiac tamponade in the beginning? And what could this be broadly? And then when you find it, you fix it. So very interesting case. Thanks for presenting it.
Yeah, again, congratulations. Excellent case, Dr. Marta. Excellent, very didactic. Learning points, I would say that the patient physiology is the king. I mean, how is the patient and what are the injuries? I think both cases were excellent at that. Operative management of trauma is still required, even in the age of angiography. But you need angiography for some injuries to help deal with some injuries, and this is an outstanding example of this. Congratulations to both presenters. Thank you very much for the kind invitation, and see you some other time.
Thank you both, Dr. Hout and Dr. Alexandrino. Before I let Dr. Martos close, I'd like to remind everyone of Dr. David Feliciano's passing and the deep loss that the trauma community at all levels worldwide has suffered. And I would have us all think and have their family in our thoughts and prayers. Dr. Martos.
Yes, just to that to you, it was a huge loss. I would like to say thank you very much for our presenters and panelists for being here today.
Can I say something, Dr. Martos? Can I, excuse me, can I, sorry to interrupt you. If I may, obviously condolences for Dr. Feliciano, but I would also like to leave the invitation to join us in the European Trauma Surgery and Trauma and Emergency Surgery Congress this coming April in Estoril, Portugal. And join us. It's from the 28th to the 30th. Thank you. That's it. Thank you very much.
Thank you very much. So we're gonna have our next meeting in February. Please, if you have some good case, if you want to be the moderator and lead the meeting, please contact Dr. Pascual or myself. So looking forward to booking the remaining of the year's presentations. So just echoing Dr. Jose Pascual's words, I would like to finish this meeting with a minute of silence to honor the memory of Dr. David Feliciano. Thank you very much.
Thank you.
Thank you.
Thank you all. See you next month.
See you.
See you.
Bye-bye. Okay.